Part two of the Neuro lectures is going to address the assessments that are important to make. When we look at level of consciousness in a pediatric patient, as we've said repeatedly, in our younger kids, we're talking about the behavior. What are they like? Are they doing what they're supposed to be doing? Or are they irritable? Are they restless? They won't go to sleep. They're arching. So instead of folding forward when they're tired, they have so much pressure on their meninges, for example, they start arching backwards. Are they crying? But the cry is different. The parents will say, it's not as strong as it used to be, or it's so high-pitched, or it's very shrill. Does this child recognize their own parents, or do they just not care? They just look around the room, and it doesn't matter who's in there. Are they resisting when you expect them to? You go to start an IV, you expect that baby to be crying, right? Well, this baby is just laying there. You can do whatever you want to it. Is there more sleeping than usual? Is the baby feeding? Because remember, that's one of the things that is key in a baby that can't do much of anything else is, are they feeding? So they should poop, they should pee, they should eat, they should sleep. But all of a sudden this baby isn't feeding. And of course the parents initially are just saying, oh, they're such a good baby. But you look at the kid and you're looking at him like, what is going on with this kid? There's something not normal. Is the child alternating between being lethargic and then they're irritable and then they become lethargic again? And that lethargy is lasting a little bit more than the irritability. Are you having a difficult time getting this kid to wake up? And then, is the baby not waking up at all because they're in a coma? In our older children, we're looking at very similar things. But some of the other things that they will have is that they're just not their usual selves. They're cranky, cranky, cranky. They start acting out, they start being belligerent, or they start being aggressive where they used to be the sweetest little kid. You can go ahead and ask them about their orientation. Simple things. What's your mom's name? What street do you live on? Who's your best friend? Of course, you need to know the answer to those in order to make a determination on whether or not this kid is okay. And then you're also looking at them in terms of sleepiness. Are they exhausted or are they actually lethargic? When you have a child that you're not certain about what's going on and you need to stimulate them, we want to use the least amount needed to get a response. You don't have to go straight to the sternum and do a sternal rub when you can gently shake the kid, or you can pinch their nail beds a little bit, or you can do something even nicer, tickle their feet, rub the spine. What you want to see is that they should move and their eyes should open. But you also want to observe, are they having posturing? Meaning that they're stiff and their hands and feet are turning inward toward the core, which would be a decorticate posture, or they're going the opposite direction, and that would be decerebrate. Are they answering your questions appropriately? After you stimulate them, do they have a higher level of consciousness, meaning their behavior is a little bit more appropriate in what you would expect, but it's not quite right? Do they stay awake then once you get them to wake up? Or do they return back into that lethargic baseline? We do have a Glasgow Coma Scale that is specific to children. And remember that when you're doing a Glasgow Coma Scale, the verbal and motor responses have to be adapted to the developmental level of the child. And keep in mind that the range, when we're doing the Glasgow Coma Scale, is between 3 to 15. The lower the score, the worse the prognosis. And here is a copy of what the Glasgow Coma Scale score assesses in an infant less than 1 year, late infant, preschool age children, and then once they hit age 4, It's the same parameters that you learned in 172 for the adults. When we suspect a neurologic problem, it's very important that we monitor the trends in the child's vital signs because it's going to change. Are they tachycardic and then all of a sudden they become bradycardic? If they become bradycardic, this is a late sign of brain injury. What is the quality and the rate of their respirations? Are they slow and then they become rapid and noisy, the Cheyne-Stokes? Are they agonal? This is not good. It means the brainstem is affected and there's potential for the brainstem to herniate into the spinal canal and can cause death. The blood pressure is very important because we need to maintain the cerebral perfusion pressure. So if we start seeing an increased systolic pressure and then a widened pulse pressure, that's part of the Cushing's triad, and that's a late sign. So Cushing's triad, and we use the same thing in adults, bradycardia, the widened pulse pressure, and then respiratory changes. And in a child, it's the respiratory changes that will occur later rather than sooner. So watch for the bradycardia and the widened pulse pressure. The infant, there's an additional assessment we can make. We can look at their fontanelles. Is the anterior fontanelle still open? And if it is, good. Is it soft and flat as we would expect it to be, or is it full, tense, and bulging? Now make sure when you're checking this that the kid isn't crying, because when they're crying, it's going to make it tense and full. And that's not an accurate assessment of neuro. We can measure the head circumference, and when you're doing this, we do it at the widest point, which is just above the eyebrow line, and it goes back to the occiput. We do serial measurements of the head for the first year of life because they should follow their same growth curve as they would with length and weight. If you have a child that's admitted to the hospital with increased intracranial pressure, you're going to be doing serial measurements and we'll be measuring that head circumference at least once a shift. And then I've given you what the parameters are, the normal expectations. You don't need to memorize this, but just look at it on a growth chart and realize that this child should follow their pattern. It's very important that we document our assessment findings because you're only going to be at the job for a certain length of time, and somebody's going to come behind you and they're going to compare their assessment with what you had to determine is this child better or worse. We want to use this detailed description of what you find. Sometimes we're limited because of what's in the computer, but that's why we have an other category. And so click on the other, describe exactly what it is that you have assessed. You want to use objective terms. Don't generalize, because when you generalize, what you think could be totally different to somebody else. So be very specific. Document the interventions that you do, and then document the child's response to those interventions. Avoid terms like patient had a seizure. It's far better for you to describe exactly what you saw. We go with the eyes were repetitively blinking, the right arm flexes, it lasted 30 seconds, the patient was pink throughout, O2 sats never dropped below whatever percentage. The doctor was notified, they came to the bedside, and no new orders received, or Ativan order received, or this order was received. When we're looking at increased intracranial pressure, we have some early signs, and the early signs are going to be headache, especially when rising from bed or with a sneeze or a strain. There can be nausea and vomiting, as well as anorexia. Oh, great, not another issue that has nausea, vomiting, and anorexia. How am I supposed to decipher? Is this neuro? Is this gut? Is this tonsillitis? And you can see sometimes these kids are very confusing. Watch the behavior. Does this child have a behavior change? If you're in a clinic and you're used to seeing a kid and they're Mr. Happy-go-lucky and all of a sudden they come in and they are cranky and mean and saying this or doing that, that's a definite personality change. It's like the opposite of what you know. Do the parents and or teacher report changes in the child's schoolwork? They used to be very, very neat, and now all of a sudden you can barely read their handwriting. And this can be indicative of a neurologic problem. And then, of course, we have the restlessness, the irritability. Ataxia is a big one, especially when we're talking about brain tumors that are compressing on the cerebellum. And so you get this broad-based gait. And then, of course, we can have visual changes where the child is complaining that they're having double vision or a quick onset of blurry vision. So this ends part 2 on assessment, and we're going to move on to diagnostic imaging.